Welcome to the Women's Health Podcast. I'm Antony Lowe, the Physio Detective.
And I'm Marika Hart, a pelvic health and musculoskeletal physio. Together we interview leading authorities, we answer questions and share our thoughts to provide the general public with the best quality information that we can find on all aspects of women's health. Please remember that the materials and the content on this podcast are intended as general information only and are for entertainment purposes.
They're not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now, sit back, grab your favourite beverage, or do your own thing, and enjoy the show. Welcome, everybody, to the podcast. And for today's special guest, we've got our very own Marika Hart. Welcome to your own podcast, Marika. How are you going?
Thanks, Antony. Yeah, I'm going pretty well. How are you?
Pretty good, thanks. I thought for this episode, I thought it would be a great topic to just go over some of the key things that you wish you knew as a new grad, or, things that you've learnt since, more into pelvic health, some of the lessons that you've learned and some of the stories that you've heard and seen and experienced, and thought would just benefit from your wisdom. So thank you for agreeing to do this.
Oh, it's really funny being on this side, Antony, because now, of course, I feel a bit nervous because I'm like, oh God, I'm being interrogated now. But no, I'm sure we'll have fun.
I'm sure
I'll be the wise one.
Well, that's what you are every time. You're the wise one every time.
Hilarious.
So in that vein, what's I'm sure you've got some thoughts. What's a key point that you would love new grads or people who are new to their area of work? So it might be somebody moving from the public system to the private system to the public system, going from musculoskeletal or sports into, say, pelvic health or one of the others. What are some of these key lessons that you've learned?
Yep. I think one of the first ones I thought of when you asked me this question before, Antony, was it's okay not to know. It's okay not to know everything and to not know the answers. And I think as a new graduate and as a young physio, I always felt that I should know everything, which is insane, because in 4 years, how much can you learn in terms of assessment and treatment of this huge number of conditions? And so you're really at this beginning of your journey and you know such a small amount, but there's that feeling like, oh, I don't want to admit when I don't know. And I think one of the blessings that comes with, in part, age, but also experience, is that you learn, you get that confidence to actually say, I have no idea. I don't know what's going on. To admit when you don't know, and to then say to the patient, well, actually, I'm not sure about this, but let's go and talk to some other people. Or I had a patient the other day, she was quite funny actually, because she mentioned a medication and it was one I'd never heard of. And so I said, oh, can you spell that for me? And I was typing it in and she looked at me, she's like, you should know that, or something like that. And I said, well, I don't know all the medications. So I'm learning from you, and I'm glad to be learning this. Or patients will come in with probably less common conditions and they'll mention it to me and I will say, oh, I've not actually heard of that. Can you tell me what you've learned about it? Or, maybe we can have a look at it together. So there's that feeling of, being okay with not knowing everything and knowing my limitations and what I feel comfortable treating, and then just actually saying, you know what, this other person is so much better at that than me. Like I'll send you that way. And if I think back to like my pelvic health journey, I think of when I started, I came from a very musk background, Antony, and worked. Then kind of when I had children, went into more obstetric kind of pregnancy, postnatal exercise, that kind of thing. And then I did some short courses in pelvic health, and I was at that really early stage, and then started looking at, doing some more vaginal examinations and being able to treat some pretty basic stuff. But I remember having a patient came in who had urgency So she had urgency and frequency of her bladder. So I was, I did a pretty decent subjective assessment. And then when I thought about it, I was like, I actually don't know what to do now, because I hadn't done any of the courses in overactive bladder. I hadn't really worked with people with urgency before. And I just felt a bit sort of, oh shit, what am I going to do? What am I going to do now? But I was really glad, because I could kind of stop and talk to this lady and say, look, here's some basic information, but actually I feel like I'm at my limits of, knowledge and skills here. So I'm going to pass you on to a colleague who works nearby. I think she will be able to help you. And it really solidified my decision when I called the physio to give a handover, and she asked me a whole bunch of questions. And I was like, yeah, I don't know. I didn't ask that. And then made me realize, like, yeah, I did not have the skill set for this patient. And that's okay. The patient was happy, went and saw this other local physio who did a great job. And obviously since then I've gone down a journey of learning more about it. But I think that comfort of just going, it's okay not to know. I don't know everything. I'm never going to know everything. Every day I go to work, I learn something new, and I just think, oh, that's what's like, I feel quite grateful for that, because we're always learning something new, right? And that kind of, it's quite freeing to admit to yourself, like, I'm never going to know it all. Like, I'm just not. So that's okay. I'm just going to keep learning and ask questions and crack on. That was a very long answer, wasn't it?
Doesn't matter to me. We're getting all the wisdom from you, Marika. I'll take it all. So not knowing it all, and thank you for sharing an experience with a patient. And I guess you and I are both privileged in that we live in big cities. There's over 1 million at least in your city, and there's over 5 in mine, and
over 2 in mine now. Thank you very much, Antony.
Oh wow!
We've cracked 2 million in Perth.
Look at it go. I think it's still the most remote city on Earth, with over
Capital
1 million
city,
population. Yep. Yeah, like crazy. Anyway, the the benefit of being able to do that, and some of our people, there's nobody else to see for hundreds of kilometers or miles, right? And hours away. Have you ever come up against anything like that where it's like, you know what, nobody around here knows about this? Have you ever had that type of situation?
Yeah, we do actually have that a lot. So with my role I work at King Edward Hospital, which is the major women's health hospital in WA. So we cover all of Western Australia. And as you know, Western Australia is bloody big. So some patients will be literally over 1,000 kilometers away. So they will fly down to see us and then fly back. So we work a lot with rural, how I struggle with that word, like country physios. And a lot of them are generalist physios. So they do everything. And I love country physios, and they're so talented, because they're doing neuro and cardio and everything under the sun. So these physios, so we will work with them, because a lot of them have not been trained to do vaginal examinations or anything, but we will kind of do joint sessions with them to try and upskill them and help them support patients locally. Otherwise, we're quite lucky, because our patients do get funding to fly to Perth for sessions with the urogynes and with us. So that's our situation here. Like, I know with my work in Girls Gone Strong, we'd have people in places in America that literally they're saying, yeah, well, it'd be great to go see a women's health physio, but they're literally 8 hours away. Like, there's just no way. And I think one of the blessings that we've had through COVID, of all the horrible things that came with it, is that people have got a lot better at telehealth. I think we realize that we can help a lot of, I know you've been doing that for years, Antony, but we can help a lot of people online. It doesn't, we don't always have to be putting our hands on people to actually help people. And, to be honest, a lot of what I do these days is not hands-on. So yes, I still think there's a lot more opportunities now than there used to be. Well, someone's trying to call on my phone, sorry, for patients in more remote areas, because yeah, it traditionally has been almost impossible.
Yeah, it is a difficult one, right? And like I said, when you go and hear these stories from all over the place, it's yeah, it's really difficult, and people feel that pressure. And I guess on that last one, on the, you know, not knowing and being able to hand off, and I know that you do some mentoring work, and you more senior type roles, and you've done that for a while. How does it look for the younger graduates, the newly graduated, the earlier in the career or early in the change type thing? How does that look from your point of view now, from the other end, from the mentoring, more experienced
Do you mean
end?
for pelvic health, or do you mean just in general?
Yes,
Pelvic health?
in
Yeah.
general, pelvic health and in
Oh, in
general,
general?
yeah, as well,
Um,
right?
that's a really good question, because of course I'm in my little bubble, so I kind of know what's around me. I think I still feel like for a lot of people in private practice, it can be very isolating, especially if they're in small private practices and sort of chugging through large number of patients. If they don't get really good support in that environment, it can be quite hard to upskill. Um, I've always been quite actively involved, I guess, with like the APA, kind of going to courses, or I had a little bit of time on the committee as well. So I've always, I guess, wanted to keep in touch with people in other fields and around Perth, and learn, through the lectures and stuff from other people, which I think is really valuable. I do know that I have noticed that there's a lot more mentoring programs available. And again, I'm talking about pretty much in Australia, but I know obviously you've got an online mentoring program. Our good friend Kieran, who we spoke to a couple of years back, who runs Global Global Education Physio something. Sorry, Kieran.
Yep.
But he's got a team who they're all very, very good physios who do online mentoring. And there's quite a few pelvic health physios. I know Natalie McConaughey, who we know and love, does mentoring and stuff as well. So I think there's a lot more people who are opening up to doing mentoring, which I think is so valuable. And the APA actually has a mentoring program for junior physios, so more senior physios can offer their services, and the more junior physios can sort of log on to that. So that's, yeah, I think there's a lot more opportunities than when we were young. I think when we were younger, it was probably more to do with the people that we worked with, and then access to in-person lectures was pretty much it back then. Back in the olden days, Antony.
Back when I had hair. Beautiful. What about some other things? What other messages would you love to share with people? Or even your younger self?
I think one of the things that I've learnt, which I wish someone had said to me when I was younger, was that you just can't help everyone. I felt like a lot of my identity and, was kind of in being a successful physio, was being able to fix people, and having people, walk away feeling better. And so if they didn't, then it was me. I did a shit job. I'm a terrible physio. I did something wrong, blah, blah, blah. And I think we take all that on board as being it's our failure. And now, many, many moons later, and the patients that I have, are really, really complex. And there's so many of them that you just think, well, I'm not going to get you better. Like, I really hope that I'll be able to assist you in some way. But I'm probably not going to make your pain go away. But also, I think there's a certain, that's quite egotistical to think like I'm this magic person that I can fix people, because that's not the reality, is it? Like, their bodies are healing themselves. And probably when you work in musculoskeletal physio for a long time with people with acute pain, they're going to get better anyway. So you do something and they feel good, that's great. But probably 80% of them, 90% of them, we know statistically are going to get better within 6 weeks, whether you do anything or not. So you kind of get used to having this, like, this patient comes in with this acute problem, I help them, they get better. I'm pretty awesome. And then when that doesn't happen, there's the flip side of that, which is I'm shit. Like, I'm a terrible physio. I haven't done a good job. And now, I guess further down the track, I have these patients who come to me. This is not a particular patient. This is just an example of the kinds of things that I'll see. I'll have a patient coming in with, 20 years of pelvic pain, who's had dysmenorrhea since they're 14. So painful periods, never been able to have sex without excruciating pain, has had 4 laparoscopies, has excision of endo, has had a hysterectomy for, trying to cure, in brackets, the endo, has tried every oral contraceptive under the sun, has been to the pain clinic, is on pretty significant amounts of, anti-inflammatories, opioids, all sorts of things, has bladder and bowel dysfunction, can't work, and this will be a patient who walks in the door. And if you sort of think, oh, I'm a failure if I can't fix them, well, you're kind of screwed. So yeah, so they're the kind of patients that I'll often see now. And so I've kind of let go of that expectation of myself that my job is to fix people. And, we're there to sort of walk alongside our patients. We're on a journey with them. We're not carrying them. We're helping support them in their healing process. And sometimes the best we can do is actually not doing anything. I'm actually thinking of a patient I saw a couple of years ago. She had really severe bladder pain, 15 years, I think, of bladder pain. And she had gone to America. I think she'd had all these bladder installations of different things. She'd had Botox. She'd had, she'd had every medication under the sun. She'd had physio a long time ago. She was wheelchair bound when she came in to see me, probably in her early 50s. Such significant pain. So she told me her whole story, and I said to her, and like you, Antony, when you sort of always say to them, like, how do you think I can help you? Like, what are you looking for from me? And she just paused and she looked at me and she just said, I just want to be left alone. And I said to her, that's okay. Like, you don't have to have physio. And she said, I don't. And I said, no, you don't have to have anything. Like, if you don't think I can help you, no, that's absolutely fine. Like, I don't mind what, and she got a bit emotional, and because her husband was the same. And he said, every time someone has tried to help my wife, she's ended up in more pain. Every intervention she's had has made her worse off. We just want to be left the hell alone. And I said, no problem. That's absolutely fine. And so we sat down and talked for a bit about, I just said, look, let me just explain to you, if you wanted to do physio, these would be the things that we do, but you can head out that door. I will never be offended. You do not have to have physio. And I think sometimes our patients feel almost like a obligation to us, don't they? Like, they want to be well behaved and good and do the things that they're told to do, even if it's not necessarily the best thing for them. So I guess that was another long-winded answer, but I now don't hold my identity into fixing people or making people better. I hope that I help the vast majority of my patients, whether that be that they can, play sport or go back to work, or maybe, have intercourse, be intimate with their partners. But, I'm not looking to be their sort of savior and fix them. That's not really my role.
It's a very humbling experience, isn't it?
Yes.
To be able to get that every day, all the time. And if you really do, place your identity there, it really does suck. It would suck if just every day you just saw the hardest of the hard, right? Like, they've seen everybody and they're not better after decades. Like, that would be pretty draining if you place your self-worth in there. So sounds like a lot of wisdom going on there. Appreciate it.
And I think, what's related to that, Antony, and I've learned a lot about this from you, is just our role as more of a coach with our with our patients. And like I said before, when we're kind of walking alongside our patients, we're giving them options. And I learn a lot through my work with Girls Gone Strong, where I was writing some of their content for the pre and postnatal certifications, but then I would read through the rest of the content, and we talked about motivational interviewing and reflective listening and all this kind of stuff. And these skills that have been so helpful, because when you have these really complex patients and we do this full examination, the most important thing is finding out, what do you want? What do you want from me? What were your expectations? What do you think is going on? What do you think is going on in your body? What do you think is going to help you right now? And then giving them options, and then putting the decision back on the patient. So what is it you think you can do right now that might help you? And just an example of this, I had a patient who was a mesh complications patient. So we see quite a lot of women who have had mesh pain, and she'd had 15 years of pain. She was pretty grumpy. They were her words. So the first time we spoke, she was really angry and really frustrated. And for those who don't know much about the mesh debacle, I think a lot of our listeners probably would, and I think we probably should do a podcast on that actually. But a lot of women around the globe had mesh put in for prolapse, for incontinence and other things, and thousands of women have been really significantly affected through infections, inflammatory chronic conditions, severe pain, disability, all sorts of things. So she was a lady who had to quit her job, has never been able to have sex since. She has daily pain. She's very angry because she's like, why didn't anyone tell me this could happen? She'd had the mesh removed, which did help, but she still has ongoing pain. And she was very frustrated. And she sort of, the next time she came back, because I'd said to her at the end of the first session, I said, right, thank you so much for telling me the story. When you come back next time, I want you to come up with a couple of goals. Think about what you want from me, because I want to help you. What do you want? Tell me next time. So she came back a couple of weeks later for a next appointment, and she said, first of all, she said, I'm really sorry that I was so grumpy at you last time. And I said, don't worry, I'm quite used to it. When you work in public health, people often get frustrated with wait lists and all sorts of things. So I was like, don't worry, I'm used to people getting grumpy with me. It's fine. And then she said, I just want to feel a bit stronger. I'd really like you to give me it. And it was quite surprising because I didn't think she was going to say this, but she said, I just want you to give me an exercise program so that I could feel a bit stronger in my body. Because every time I do something a little bit too much, it takes me a day lying down to recover. And I feel like if I was a bit stronger, I might be able to do a bit more. So I said, great. What do you imagine in your brain that to look like? Did you have any ideas? And she's like, oh, not really. Okay, do you have any equipment? No, not really. Okay, well, should we go into the gym and have a little bit of a play around? So anyway, so we went into the gym and we did some things with some TheraBand and just some basic bridging, squat combos, some arm exercises, just 5 or 6 really simple exercises. But as we were doing it, her face, Antony, just completely changed, right? She was smiling. She was almost glowing. And I was like, okay, so when you're doing this, you should be feeling these muscles working. She's like, oh, wow. Yeah, I can really feel that. And she just got so excited by this concept of just having, and she's like, how many times a day do I have to do these exercises? And I was like, no, just do them 3 times a week would be great. Let's do this. Let's start with that. And we're going to build you up really slowly because you've been deconditioned for a very long time. And we know your nervous system is very sensitive. And if we do too much, you're just going to, flare, and then you're going to want to chuck it all in. But I think that's just a really good example of kind of coming back to, I could have done, I don't know, I wouldn't have done internal releases with her. But, you can get stuck into ways of thinking. But she made the decision as to what she wanted, which actually made my job really easy because I'm like, okay, what you're after is very reasonable. It's going to help. We can help with those goals. That's very conceivable. And it fits in with, I guess, what we're always trying to achieve, which is helping people become more functional and have a better quality of life. Yeah.
Yeah, it's you haven't outright said it specifically. You did in that answer there. Like it sounds like the communication skills is very different to the way that we were taught in undergrad and postgrad, right?
Absolutely.
Like even postgrad. Um, you know, what are you seeing in the younger graduates over there in terms of style? Because usually especially to the master's level, like there's three tiers in Australia for everyone listening. So there's a specialist level, and then there's the master's titled level, and then there's the undergraduate. This is where most of the physios sit. Um, and both you and I have got the master's level. You got two masters, and I would say just to there it's making sure you check all the boxes, making sure that you do all the things right. But that next level, specialist level, is much more about what's really important right now. And it's just that higher level thinking, which, to be
Mm.
fair, I think you operate up there, Marika. So,
I'm getting there, but
you know,
it's a yeah, it very different though. No, I sorry, continue. I cut you off.
no, no. What are your thoughts? Like you just started answering, which is great.
Well, I think I understand why we have to do this. So in our undergraduate and even in our postgraduate program, the questioning is often very much about we're formulating a diagnosis, right? And differential diagnosis, and we're excluding red flags. And we have a thought process of this is the information that we want, so we can find out what is going on, so we can treat the thing and get them better. So I think that is probably how you and I were both trained back in the 90s. And very late 90s, very late 90s. I think things have probably changed. I still think in the undergrad you kind of have to go through that process, and I think it's really important. And even in the postgrad, in pelvic health, we have to be able to ask all these questions. We have to understand: does someone have symptoms of voiding dysfunction? Do they have symptoms of defecation issues? Do they have prolapse symptoms? So there's all that all the questioning that you have to get. Where I think most of us, and this is me as well, don't have a lot of training is in all those other soft skills. And so, for instance, like you think about people like
Can
Peter
I
O'Sullivan.
can I interrupt you for a second?
Mm.
Just want to jump on it. People call them soft skills, and I know that
Yeah, it's
everybody
annoying, isn't
refer.
it?
They're really difficult, hard
They really are.
skills. So the communication skills, right? Can we call them communication skills?
Yeah, absolutely. It's funny you say that because that's the word. I don't call them soft skills, and I don't know, that word came out, and I was like, that made me feel a bit cringy, actually. So I'm glad you picked me up on that. So you look at people like, Peter O'Sullivan. I was going to say he's doing his, CFT, and there's lots of different styles of, I guess, working with patients. And I know with you had your sort of like foot indoor, was it? Hang on, foot door in face. Different ways of working with patients depending on what they're after and what you think they need at that particular time, etc. So there's lots of different ways that we communicate. But I think I'm trying to, I don't know how to answer that, I guess. I think a lot of it you kind of develop with experience and with age. And in the postgraduate programs, there's some of it, but I think a lot of people learn those skills outside of university programs, to be honest.
Bias declaration. That is the course that I'm working on. Assessment done differently. So
Oh,
yeah. Just lots of people keep asking for it and wanting to know how you do that and putting it all together. And so, just trying to codify what we do. I don't believe that I'm unique in the way that I work. Maybe some of the words and phrases, but everybody's got their own, like that's what makes us interesting.
yeah, for
Yeah,
sure.
those communication skills, right? And watching a new grad go through, and it's like because you were looking down or because you were thinking about the next question, you just missed that little hint that they gave you in the way that they said that answer, or that little
Mm,
pause, or that little glance, or that little
mm,
twitch that they had, or like, how do you communicate that? And then how do you teach that? Like, how do you teach people to
mm.
look for that when they're really trying to get through that list? Especially in America, where you've got to fill out all these online forms for the insurance companies. And yeah,
Yeah, I see that with the undergrads because you ask a question, but in their minds they're already thinking like, oh, what's the follow-up? What's the follow-up? What's the follow-up? And then if the patient answers that question in a way that they weren't expecting, it completely throws them. And I was saying to the undergrads, because often they don't want to bring in like cheat sheets or other stuff. And I'm like, I don't care. I have a terrible memory, like I forget stuff all the time. So I'm going to have cheat sheets. I'm going to have, like if the students are doing education on the ward, I like them to have the booklet with them so they can remember, like, let's go through the bladder stuff, the bowel stuff, like pelvic floor muscle, whatever, so that you know that you've covered the things. And then at least you're not trying to make sure that you do all the right things in front of your supervisor. You can actually then, like you say, look for the cues, respond to the patient, be in the moment, like be present with that patient.
and honestly, I think that's where our job really does really well, right? I think us being able to interact with people is a big difference. If it's just about knowledge, well, then AI is coming, and
Mm,
it's going to be fine. But it's not just about knowledge, right? It's about that interaction. It's about that dynamic, which I think is really important. So
so important.
so important. What else have you got for us? So we've covered it's okay not to know. You
Yep.
can't help everybody. You're on a journey, you're kind of coaching them. The
Yep.
communication skills in along with that coaching, I suppose,
Mm,
because we don't get taught those, and you can do courses on them. Um, it's difficult. What
mm.
other what other things do you wish your younger self got told?
Well, one of the things I did do, which I'm really grateful for, but no one told me to do, but it just is what happened, was, I think diversifying early is a really good move. I think people struggle when they specialize too soon in the career. And I'm assuming it's probably pretty similar around the globe that as, an undergrad physio, you do neuro and cardio and like respiratory and musc and all the rest of it. So I think in terms of pelvic health, where I see people struggle is when they do an undergraduate program, maybe work for a year or two on a ward, just, I don't know, giving pregnancy women, postnatal women a bit of advice, and then going on to do postgraduate courses and things like that, because all those other skills that you haven't actually had a chance to practice are so helpful. And like for me, when I was, my first job actually was in a public hospital in Perth, and half my job was doing outpatients, like normal musculoskeletal outpatients, and half my job was working in a day hospital. And I don't know if you have these in Sydney, but it's kind of like older patients, so between 70 and whatever, would come in. They would see the geriatrician, OT, physio. So we would kind of treat neuro, everything, like, and then run exercise classes, and that was really good because I just got, I could auscultate people, I could do a neurological exam, all these things that I probably forgot now. But then spent a lot of years doing like musk physio, and I think that's been so beneficial having the musk background working in pelvic health, because I just don't know, I couldn't do my job without it. Like I just couldn't, like how do you differentiate between, sources of pain if you can't do a basic musk assessment? And an example of this, Antony, is I had a patient who had this a few years ago. She'd had a TBT, so a surgery for incontinence. 5 years later, she developed some anterior hip pain, but it was around the time when the lawyers contacted her from about the mesh case. So in her mind, she's like, oh shit, this is my mesh. So she's come through the mesh clinic and they've said, oh, look, I don't think this is your mesh, because they did an internal examination. There was no pain, no exposure along the site. And like just being able to talk, to do a good assessment and just find out, is this behaving inflammatory, mechanical, what's going on, and then assess her hip. And it was very much more a hip problem, but then give us some exercise and reassurance and be able to say, actually, this seems to be coming from your hip joint, was really helpful. And for a lot of our pelvic pain patients, being able to screen the back and the pelvic girdle and, do a neurological assessment is really important. So when I have the undergrads come through and they come and they sit in and they're like, oh my God, this is amazing. I really want to be a pelvic health physio. This is so cool. It's so interesting. And I just say to them, come back in 5 years. Like, do not just go do something else. Like, go do other stuff and then get some experience, get some good experience just being able to do subjective and objective examinations and do a good MUSC assessment and then come back. That's my personal recommendation. I know people are going to disagree with me, and that's fine, but I really, really think that it's helpful.
Yeah, and it's not wrong, right? It's not wrong to just, you've got a heart for it, you've done your degree, you want to graduate, you want to get stuck straight into it because that's where your passion lies. It's not wrong to do that.
Yeah.
It's helpful to do it, like you said. It's helpful to do it. Come back in 5 years. Yeah, go do some other stuff. Yeah. And I guess the flip side of that is for all those in musculoskeletal ortho, physio, don't turn away your pregnancy, early postpartum people all the time. Like there are some people who say, oh, you're pregnant? No, go see this person. There's so many things, and that's how I got started. Because that's what I was doing. I was doing the prenatal, postnatal work in the hospital and carried it on in private practice. And the more you experience, the more you learn. The more you learn, the more you realize you don't know. The more you realize you don't know, the more you go learn more. So I haven't gone down the master's track. I won't go down pelvic health masters, and I won't do internal exams, and that's okay. Got plenty of great people like you to do all that stuff. But I think the thing, hopefully, that I appreciate is how much I don't know. So the things that I do know about, I'm happy with. And I know that it's just a small subset of what's out there. You know what I mean? And so that's really helpful to hear about that diversification, because I'm kind of the same. Sports physio, sports injury, sports performance. So no symptoms, just wants to get faster, run faster, jump higher, lift more, and
so helpful.
And pelvic health, and they just all mix in together. They all mix in together. It's fun.
But I think if you know a little bit about lots of different areas, you can also recognize things and just at least pick up on things and refer on, because you'll pick something up and you think, oh, I remember that from, like even from your neuro days, you're just like, oh, this could be a more neurological problem. Maybe they need to actually go down a different path. Maybe this bladder problem is related to, it could be something to do with their brain. This might not be a primary bladder issue. So being able to, ask questions and delve and then kind of have that, a little bit of suspicion there and then handball on is helpful.
Yeah, I saw somebody this week who, had landed awkwardly on somebody's foot in volleyball. So the person's foot had gone underneath the net and they landed on it and they twisted awkwardly. And they came in limping, crutches. This is a couple of weeks ago they came in, and I'd taken my time and written a proper letter with everything that I saw. and I think the early X-ray showed a little bone fragment medially, and you know, lateral swelling, lateral ankle pain, but really tender medially. And so it's like, what do you do? I don't know. They've got the X-ray already. They've got this. They've got that. I did all the tests. I'm like, no to syndesmotic injury, right? So no to that distal tib fib separation type injury. I think you've done your lateral ligaments, but it's not too bad. Like honestly, I plantar flexion inverted and inverted with dorsal. Like I did all the different ones, glides, everything, didn't flinch. Has a really good pain tolerance. You know how everybody tells you how good their pain tolerance is? It's kind of like LeBron being the GOAT. LeBron's not the GOAT because he tells everybody he's the greatest of all time, right? Michael Jordan never tells you how great he is. Other people tell him how great he is. This kid, I had to tell him, like, I think this is supposed to be painful. And he goes, it's a bit sore, which, because you're getting a feel for how he grades. Anyway, they had this pain, MRI. So goes to see the surgeon, the specialist. The specialist goes, I'm 80% sure. We could just go do an operation. I'm 80% sure you've got a syndesmosis injury. And the mum had sat here and watched me type out this report, right? And she's like, the physio did an extensive examination and has written you a report. Have you read it? And he's like, no. Like, it's completely dismissive. And I get it. All of the times the reports are like, but like I did a good report. I did a good exam. No syndesmosis. I think there's lateral ligament injury, but he's done it a few times in the last 6 months. But I think he's got bone bruising medially because of the inversion injury. Anyway, MRI, never seen this before, Marika. His MRI, medial malleolus, bone bruising, right? Like white bone, like bone bruising on the dark, the dark style MRI. It's full of fluid, it's full of blood. But no kissing injury. So no contact point on any of the other bones to cause that. And I said, I think what really happened was you twisted so hard, you almost broke the bone. Like you almost broke the bone and it was about to snap and you hit the ground or something and that was it. Because there was no contact injury, nothing. And part of the reason why is because they'd asked me, they said, how long until he can play? Because the surgeon said, and I know that we make fun of this phrase, but the surgeon had said, this is the worst bone bruising of that bone that I've ever seen with no other bone bruising anywhere else. Like I swear he must have been so close to snapping that bone. It was like, I don't think he was trying to be nice to them either. Like I think he was baffled. That's the way the mum described it. Yeah, he seemed like really concerned and like, don't play. Like, don't play. You got to let this heal up. You almost broke his leg. So, it's just one of those things, It's diversifying early helps you catch those,
I was wondering when you were going to bring it back around.
Out of the box. Yeah, the Ottawa was positive. Send it away. Could have sworn he had a stress fracture. Doesn't have a stress fracture. Got bone bruising, but not stress fracture. Yeah. And I suppose.
Yeah, no, you're right though. Like having skill sets from different areas and just kind of being able to kind of go, and having that experience that you've had in different areas enables you to kind of go, this is different. Like this is not behaving as I would expect. Like this presentation, there's something just not quite right. And you just get that little spidey sense. And you're just like, yeah, I'm not happy with this. I think we need to, push for more investigations. Which feels like a lot of my job.
Right, because you're literally your referral bias is we've seen everybody, right? Like you're the major center for women's health. You're not seeing the firsts. You're seeing the lasts. It's like, yeah, we've
Yep.
gone through everybody. Here we are.
Yep. Had physio. Had physio.
Yeah. Yeah. Had physio. Lots of people have tried.
Yeah.
Yeah. Any other things that you want to share? Lots of good stuff so far.
Yeah. Yeah. I had three more. One will make you laugh, but not everyone's gonna like you. Not everyone's gonna like your style. And I think as a female, like growing up, we kind of, well, I say we, many women, we kind of want to be liked, um, try and please people, and we get very hurt feelings if someone doesn't like us. Or and I think what's quite nice when you hit middle age. See, I'm not going to say how old I am, but yeah, you know how old I am. But anyway, there's just that point in your life where you're like, I don't care. Like, not everyone's going to like me, and not everyone is going to like me as a physio, and that's okay. Like, it's not a problem. And you mentioned before about us all having different styles and the benefits of that. It's like, great. What I've said is not connecting with you. Great. Why don't you try Antony? Because he's got a different way of looking at things, and you might like his way of looking better. Or, I'm really lucky to work with some incredible physios. So if I feel like that this person is looking at me like, yeah, you're full of it, I'll say to them, hey, would you like to get a second opinion? I can book you in with one of my colleagues. And if they stay with that colleague, no problem. So it's kind of, marketing, they're always saying, if you try and market to everyone, you're marketing to no one. It's, I feel like in some ways in physio, it's a bit like that, because you just can't be out there to please every person. Like, you've got something to offer, you've got a style, it's going to work really well for a lot of people, but there's just some people who just aren't going to be buying what you're selling, and that's okay. Sometimes you just think, oh, they don't like me. And then you just kind of go, that's all right. I don't like everyone either. We don't all have the same favorite hairdresser or anything. So that's okay. There's plenty of physios around. There's plenty of amazing people doing amazing stuff. So that's fine. If they don't like me, they can go somewhere else. That's it just doesn't bother me anymore. Whereas the young me, oh yeah, I would be emotionally hurt. I don't imagine you getting too emotionally hurt, Antony.
Oh, I do. I
Oh, you
do.
do?
Yeah. Yeah. Of course I do. Because I want to please and I want to serve. And it's why I got into physio. I wanted to serve. Like, I could either do IT or I could do physio. And I decided to do physio because I wanted to serve. Like, I want to make a difference in people's lives every day, not just, working IT. And
I
you
know
know
you
what
want to
I
help
do?
people. You, like, if someone
But it goes
doesn't
for
want to be
people
your best
pleasing.
friend, okay.
It goes with people pleasing, right? Like, and then, like, my job at university, well, like when I was in school and university, was 6 years in retail at Dick Smith's Electronics. It's like Tandy, it's like literally my job was to problem solve and to help them get the product that they need. So it kind of all fits, right? And
Yeah.
it's, yeah, I do. Somebody doesn't like the course, or they give you 3 out of 5 stars, and it's like, is that fair? And I have to be careful with the I don't care. I know what you mean, and
Mm.
like to a degree, of course, there is that. But because I can let things run off, I have to check that bias and say, okay, what if it's valid? What could I do differently? And then sometimes it's just a stylistic difference, and it's like,
Mm.
okay, like there's too many people that like it this way to cater for your preference as well. But like, I'm still thinking, okay, how can I cater for that preference? In what ways could we do this so we capture more people's preferences? Um,
And I guess you're talking more about courses and groups of people, aren't you?
I am, but it's also the same with when you treat different patients, because
Mm.
You got somebody who loves their clams. I hate clams. I still give them if I have to. And because it's not about what I want and what I need, it's like if you're going to go to a Pilates class where they're going to give you clams, I've got to make sure that you're ready to go back to the class and do them. And it's not about what I think and what I want. And they're a great exercise for lots and lots and lots of people for lots of reasons, but not always the reasons that people get told. So yes,
well, I think that
I do get upset.
comes back. I think that comes back to you, like meeting your patient where they're at and helping them achieve their goals, though, rather than, I guess where I'm talking about is a personality difference or a style difference in a one-to-one manner. Because, you know, like I swear occasionally. I'm a bit more casual and relaxed with the way I'll always change my communication style depending on who I'm speaking to, obviously, but there are just going to be some people who are not going to like the way I do things. And I work with, oh my God, I have the most beautiful colleague that I work with who listens to this podcast, so she'll know who I'm talking about, who works with a lot of pelvic pain patients. And she's just so gentle and kind and compassionate. And it's not to say that I'm not that, but I'm quite different, you know, like the way that I do things is different. And a lot of my patients, they love like the way I do things, but there is always going to be people who will prefer a different approach. Yeah, I guess that's where I'm going with that. Yeah,
absolutely.
It's okay not to suit everybody.
Yeah. You know, I get people that see Hubert. You know, I work with Hubert. I refer my patients to Hubert when I'm away teaching. And some people keep seeing Hubert, and it's okay because it's not personal. Like sometimes what Hubert can offer, or like times, you know, classes, all that other stuff, convenience, of course, you know, and Hubert's great. Love Hubert. Yeah, it's just not personal. But there is, like, I think it would be indicative of some sort of social disorder if I truly didn't care, you know. It's like you get the reaction and then you capture it and then you reframe it and you remind yourself, right? And then as you get practice at it, it's a lot better. But yeah, I see too many people just writing off just because somebody's upset, in pain, really upset with how they felt they were treated.
Yep.
Like to not care a little bit about trying to understand them is also too far the other way. And I know you're not doing that, of course, but yeah, like I mean, because that would be my bias, right? My bias would be like, you don't know what you're talking about. Don't worry about it. Like, you know. And then it's like, no, what are they trying to get at? Maybe they can't communicate it in the right words that work for me or whatever. So yeah. Anyway, lots of checking.
And that's trying to get I mean, like when you run your courses, you get course feedback. When I worked at a private practice clinic, every single new patient was sent a questionnaire based on their experience of their first appointment, from a reception level and a physio level, with ratings out of 10, you know, kind of thing. So that was really helpful. Like that was just an automatic thing that the receptionist sent out to every new patient. So you're getting that feedback. And of course, we always want 10 out of 10 for everything, but don't always get that. But also, we, like in the public system, we have lots of questionnaires at the front desk and stuff like that. So you're right. Like you need consumer feedback. You can't assume that if people don't come back that they're better, but you also can't assume that they didn't come back. If they didn't come back, that they got worse and went somewhere else, because sometimes they didn't come back because they are better, but we don't know if we don't follow up. Yeah, so you're right, like getting feedback and then evaluating your services and evolving your services is paramount. Like it's essential, really. It's just finding the best way in your environment to be able to do that.
Yep, absolutely, love it. Now that was one. You said I think there was two more.
And then, you know, you probably don't want to talk all day. I had two more. One is, it seems so simple, but if someone comes to you with pain, always try and reproduce the pain. I think you're smiling and nodding. But like I think about that mesh pain example that I talked about before, and I had another lady who had she'd had a hysterectomy, and she's doing really well. Hysterectomy and prolapse repair, I think. And I'd seen her pre and post, and the surgery changed her life, doing really well. And then she said, "Oh, but I've got this, I've got a bit of posterior, which is posterior, but I've got a bit of a pain in my butt. I think it's because of the surgery, yada yada yada." Anyway, just being able to ask some questions, do a physical exam. We figured out it was probably actually just the way that her legs were up in the stirrups during the surgery, some basic stretches and exercises, and bang, off we go. But I know we've talked before, Antony, about this evolution that physiotherapy is going through, where we've kind of gone from being very bio to very psychosocial, and hopefully coming back around to somewhere in the middle. I think one really easy way to lose patients is to not assess them, and to not do a decent screen and just talk at them. And I have completely cocked up with that several times in the past. You do a really good pain science course and you're like, oh my God, that's amazing. I feel like I have all this knowledge about different, oh my God, neurotransmitters and what's going on in functional MRI scans. And you go to this patient like, oh my God, I've learned so much about pain now. And then this happens and this happens, and this is why you experience pain. And they look at you like, you're saying it's all in my brain. You're saying I'm making this up. And you're like, no, that's not what I meant. So I think being able to do a good physical screen is really, really important, and try and reproduce that pain. Because I find it really fascinating working with pelvic pain, is that yes, it might be that they have endometriosis and they have a sort of hormonally driven cyclical pain, but there's other things that are feeding into that, and maybe treating their back is actually going to help, because guess where the nerves come out anyway. Or looking at other muscles around that, maybe we can look at doing stretches or relaxation for, that's going to help settle their pain. So I think that's really important, is looking at reproducing someone's pain, because sometimes just when you press on that spot or you do that test and they go, oh, that's it. You know that experience, right?
Oh, it's the most powerful thing. I was smiling and laughing because I think it's one of the number one things that you want to be able to try do if you can, is to be able to put your finger on the pain, or have them say, nobody has been able to find that pain. You've got it. You've got it. I know you've got it. And you're not even asking them. They're going, you're on it. It's like, how do you know? And it's like, I don't know.
All right.
It's obvious. Nobody else has been able to do it. And it's like, I don't think I'm better. I just think that I've associated this with what feels tender. Because, people will tell me, oh, you'll never understand period pain. And you're right. I'll never have period pain. But you'll never know what her period pain's like either.
Yeah.
And it's like, because you can only tell your own. You can't tell other people's period pain. Oh, I got bad period pain. Oh, I know. And it's like, well, you know what period pain feels like for you, but how do you know if it's the same as what they feel like?
Yeah. It's very validating.
Yeah. Yeah. And that's what people are looking for, right? And I agree. Being able to reproduce the pain, which to me is undergrad training, try to reproduce the symptoms. But to me, that's the base level of physiotherapy training we got. Yeah.
So you I don't know if you ever saw the pictures. I did a presentation to. Sorry, my dog's doing something weird back there. Urogynaes and gynaes in Perth, and it was for, I don't know, some study day. And I was talking about pelvic pain, and then I kind of realized that the doctors don't get any training in how to differentiate between different types of pain. And so I grabbed one of the consultants and had him on the floor in this hotel ballroom thing, doing hip quadrants and pelvic girdle pain provocation tests. And they're all getting out their phones and taking pictures and videos. And I just thought, when would they, like, that would have been a 5-minute lecture in their third year or something. So we as physios, that's kind of like our job, right, is to assess and treat musculoskeletal pain. So being pain reproduction is very validating for the patient, but it helps us obviously helps direct our treatment, our management programs and stuff as well.
Yeah. And, being able to do that, hip clearing thing, being able to exclude or include or consider even just joints above and below, many joints. People
Yep.
say, oh, how many joints should I check above and below? And it's like, well, go look at the longest muscle that connects to it and go see where it attaches. And probably every joint in between, you have to go check just to be sure, if you want. Because, one joint above and one joint below is not going to do it for some joints.
Yeah.
So that's a really valid point. I was grilling somebody's this poor guy. I was grilling this poor guy on Monday, physio, and just, challenging with permission, kept checking in. No, this is good. This is making me think. But it's like, oh, if you think of a particular diagnosis, what will that look like? And he was able to tell me things of what it looks like. I said, okay, if somebody did not, like, you thought they had this diagnosis, but they don't actually have that diagnosis, what would that look like? And he was kind of stuck. Now, is it because I put him on the spot? This wasn't in front of other people. But I asked the same question a different way. And it always reminds me that we store our information in certain ways. If you see this, and this, and you do this, and this, that's often what we do. But we need to also practice storing the information in the flip side way, right? If I think they've got a rotator cuff tear, then they shouldn't be able to do this or this or this or this, instead of they won't be able to do, this. Like, they won't be able to lift their arm up, say, whatever. But if they don't have it, they should be able to do this, which means check further. And I know it seems really obvious, but people don't seem to do it. So, he watched me treat somebody, and I thought that they had referred pain from about L1, L2, and L4, right? So it was L1, L2, and L4. And I'd asked him, and they were presenting with hip pain stuff. And so I did hip testing, I did SI testing before I went and checked the lumbar spine. And then I asked him about it later. I said, you saw the diagnosis that I came up with, right? He goes, yep. He goes, I said, when do you think I thought about that diagnosis? And he said correctly, well, it must have been on your list by the end of the subjective, by the end of the interview, right? The talking. And it's like, yeah. So when did I check for it? He goes, well, you checked the movement, and then you checked the hip, you checked the SI, and then you checked the back. I said, why? And, he eventually got there to, because I don't want to confirm what I think it is, because that's the easiest way to miss things, right? You just miss things after that.
So you stop there, you confirm your diagnosis. You're like, oh, yep, cool, I was right, move on.
Yeah. And, it's one of the best things that you can do is to challenge that thinking and, yes,
but that's where your mentoring with that guy is really good. And I think back to when I did my Musk Masters, because I remember doing clinics and just having someone say, why did you do that? Why did you check that? Why did you give that extra? Just why? Like a bloody 3-year-old. But gee, it made me think. Like, but if I gave an exercise for something that I hadn't assessed, it's like, oh yeah, what? Oh, that's habit. I did that out of habit because I always give that exercise for that thing. And you go, oh, why did I do that? I didn't need to do that. I shouldn't have done, like, yeah. So that comes back to that mentoring side of things, of having someone to bounce ideas back. Which kind of, in a way, sort of leads me to my last one, Antony, which is about self-preservation and self-care and looking after yourself. And working in pelvic health can be really exhausting emotionally. It's not as physically exhausting. Like, I think back to my musk days of lots of massage and manual therapy, but hugely, well, yeah, it is very emotional. You're dealing with a lot of patients with trauma, really complex pain presentations. I think probably close to 50% of my patients have been sexually assaulted. A lot of domestic violence, a lot of, drug and alcohol, like all sorts of things. And so your days can get really heavy. And also, if you're working with really, really complex patients, you're not getting that lovely dopamine hit of like, oh, I did this thing and they got better and woohoo, next, in and out. It's slower going. You having said that, when you help people, it's incredible, because it's sort of almost more unexpected that you're going to help them achieve these goals. So it can be very, very rewarding, and I love it. But I know a lot of physios who've been burnt out, especially if you're working with predominantly complex pain and chronic pain. So I think there's a lot to be said for, and I think I hate the term self-care because it just sounds so woo, but I think almost more self-preservation. But how that looks is going to look different for different people. For me, it's exercise, like cycling to and from work, changing that uniform. So going from a cycling, putting on my scrubs, doing my work. When my scrubs come off, I put my cycling gear on. I don't think about work pretty much by the time I've left. So that's helpful for me. But I think probably the biggest thing is the people around you. So that support of your colleagues is huge. And I think I don't often cry. Well, I sometimes get like a little bit teary at work because of a patient's, they're sharing stories, so you can get a bit emotional. But I remember one day, must have been a year or two ago, I just had one of those days. It was so emotional. I had a patient who had an older lady who'd just been diagnosed with a degenerative neurological condition and was basically told to go home and Google it, which is really helpful. And her family didn't really understand, and she was trying to understand what this thing was, and she was really, really stressed about it. So we just sat down, and I Googled it, and we talked through it together. And I said, look, what you're going to need to do now is get your GP to set up, physio and OT, and you're going to need some support at home, and because it was, it's degenerative. And so we sort of went through this thing together, and she was holding my hand, and afterwards she was crying. She was like, thank you so much. You're the first person I've been able to talk to about it. So I kind of had this experience with her. And then a patient later on who was someone I knew quite well. And, you have some patients you just get along really well with. And she was very cool. And I could tell in her face something was going on. She was very distressed. And so long and short of it, I thought she might self-harm. So I had to go get the psychologist, bring the psych down. And she wanted me in the room with her. So we were kind of having this experience. And then they went to take her to emergency to make sure she had everything set up for her. And I just I walked out of the room and just bawled my eyes out for about 20 minutes. But, the people around me, it was just big hugs. Someone went made a cup of tea. Someone went and got a big piece of chocolate and just sat me down and were just like, do you want to talk about it, or you just want to sit, and I felt like that I just had this department around who would just support me through this. I knew I was going to be fine. I just needed to kind of it was just a very emotional day. But feeling like you have those people around you who can pick you up when you're struggling, who you can bounce ideas off, who you can refer back and forth to with, because when you're by yourself like this, it's hard. It's really hard work. And, your good friend, you and mine, Edwina, we were chatting for an hour and a half earlier today. We chat really frequently about some of the experiences that we have, and we did our masters together, and I'm so grateful that you introduced us, because she's been a really important person in my career and like helping me, and we share these experiences back and forth as well. So I think you've got to have your people around you, and I think also look at I've had to really work my diary and try and put some obstetrics patients in, because they're just so easy in comparison most of the time. But just having a break from really heavy work from time to time, I think, is really important as well, just to have a few simple cases to kind of work on. And I tip my hat to people who work 40 hours a week in pelvic pain, because I think I definitely couldn't do it. Like, I couldn't do it. It's hard work. It's so rewarding, but it is hard work.
It's so important. And as you were talking, I was thinking, what would I like, right? What would I like? Do I really want somebody who is human, or do I want somebody who's cold, right? And no, I always want a human. I want the human. Because of the shared experience. Like you said, we shared this experience together. And then you went straight into another shared experience that was obviously quite, meaningful and difficult, and, 2 in a row, and you needed time to recover. I think that's quite normal. I think that's, I handle things differently just because I'm just a different person, not better or worse, just different. But, quite often it's time. I had somebody I was supporting, just lots of messages consistently. They ended up needing to go have surgery, for their back. Had to have surgery in the end. And, that's not a failure. It's neither here nor there in terms of all of that. But really just wanted the best for him. And, when you're a physio,
You
to
care.
say,
Yeah.
to say, "Bow, whatever." It's like, no, I really don't like the sound of this. No, I think you should go to the hospital. This is at midnight one night. I'm like, no,
Yeah.
I know it's midnight, but I think you should go and make sure you ask for this. And here's how you navigate it. And right. And that's just what has to happen sometimes. And yeah, like I mean, if I was taking phone calls and stuff like that every day, every night, sure, I'm going to have to put a thing around it. Just like you said, self-preservation. But it's the human, and I think that's why we get on, right? Like, because we're two humans that are different, learning from each other all the time, wanting to learn from others as well. And and that's why I wanted this podcast. Because I remember when I pitched the idea at you, you're like, yeah, that'd be really cool if, people could hear what we've learned. I said, oh, no, you're the guest. You're the guest, not me.
It was
Yeah,
interesting.
I'm
It
not
was an
even
interesting
sure. I'm not
reflection. I
even
was
sure
thinking
if
about.
people, yeah, I'm not even sure if people want to hear my one. Leave us a comment wherever you listen to this
Yeah.
podcast. Let us know. But yeah, I just wanted to learn more from you, and I think your journey has been so interesting and unique, right? Um, musculoskeletal, sports, obstetric, postnatal, exercise, group exercise. You've got the student part twice, 3 times, because undergrad, masters. You've got working in specialist clinics, working in a specialist hospital, mentoring undergrads, no doubt if you're not already mentoring postgrads, uh, you know, seeing the toughest of the tough and being able to navigate all of that takes really cool skills. And so, yeah, I hope people really got lots from that. And thank you for sharing the stories and your journey. I did cut you off before. Sorry, you were
No
going to
worries.
say something.
Was I?
Yeah, I don't
I
know.
can't remember.
Cool. I just
Well,
realized it
thanks.
just replayed in
Thanks
my
for
head.
letting me. Thanks for letting me take a trip down memory lane. And yeah, I'm really happy to chat to people if they want to share their experiences. Post it on our on our socials or drop us an email. Just let us know what you think or any topics that you want us to discuss. And we'll come back with Antony's top tips in the future.
Only if they want it. Only if they want it.
I'm sure they will enjoy your wisdom, Antony.
Not sure. They're just experiences and lessons I've learned, right? Also, wisdom is often a euphemism for mistakes and lessons learned from them.
Exactly. God, that's just the story of my life.
Absolutely. All right. Thanks very much.
Cool. Thanks, everyone.
Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.